Students, can you see the slide? Please type 1 if you can see the slides. Please type 1 if the slides are visible.
Can everyone hear me? Please say something on the chat box if you people can hear me. So we'll start with our session. Please say yes. Okay. Okay, so we'll start with these spotters. I'm Dr. Purvi Malik. I'm from the Department of Diagnostic and Interventional Radiology. I'm a fellow in abdominal radiology here. So we are going to start with the spotters. I'll give you all 20 seconds to answer the spotters, and if it's a little difficult, I'll give you all 30 seconds, okay? So we'll start with the first spotter. These are pretty easy spotters, so not to worry, and we'll start. So the first spotter is this one. What is the modality? This is the first question. So please type your answers in the chat box. Come on, people, you can say anything. Is it X-ray, CT, MRI? What do you think it is? Okay, so people have started answering. Okay, so someone said NCCT. So I'll just let you know this is a CECT. Okay, so how do you know it's a contrast enhanced CT? Just think of it as an axial section and you'll see this thing, this enhancing structure. So this is the aorta, exactly. Someone said it's a vessel, right? This is aorta. Okay, so now the next question for this is, what is your diagnosis? So you all can start answering. Okay, so I'll give you all a clue. This is at the level of the kidney. So what do you think all? What do you think this can be? This is at the level of the kidney. Okay, so people have started answering. Okay, 5 seconds more. Everyone can participate because no one can see, I guess, what everyone else is answering. Okay, so we'll stop the timer here. So this is a horseshoe kidney. Many of you guessed it right. As you can see that there is some part of kidney, this is the right kidney and this is the left kidney. So you can see that there is some part of kidney that is communicating in front of the aorta. This part is called as the isthmus. So this part is communicating and it is present in front of the aorta. So this is a horseshoe kidney. So what happens is that the inferior pole of both the kidneys fuse. And that's how you know that it is going to communicate. So there are many other varieties like crossed fused ectopia and horseshoe kidney. These are all like different variants and they are pretty common. So you can see them while your scan or something. So they can be incidental also. They can be associated with other anomalies also. So one important thing to remember is that horseshoe kidney is more associated with renal cell cancers. So that is one thing to keep in your mind. So we'll go to the next spotter now. So what is your diagnosis in this case? I'll give you 30 seconds for this one. Or you can just write the anomaly. If any finding also you feel like is there, you can write that also. So we'll start the timer. Everyone can attempt. Don't think so much. Just think what anomaly or any abnormality that you can see here. Okay, so what is this modality? Just answer what is the modality. It's an X-ray, it's a CT, it's an MRI. What is it? It's an X-ray, right? So it's a chest X-ray. So you see it's a PA view, okay? Now, can you see this structure? Do you normally see this structure in chest X-ray? Like this much prominent? Okay, so no. What is the point here is that this is the right heart border. So usually the right heart border is formed by the superior vena cava, then the right atrium and the inferior vena cava. But you see some very prominent structure here. Okay, so I'm going to show you the corresponding CT. Let's see if anyone can guess. Yeah, someone said it right, Adarsh. Okay, so it's a right-sided aortic arch. Exactly. So whenever you have a right-sided aortic arch in a child, okay, so you always suspect TOF in that person. So it is pretty common anomaly associated with tetralogy of Fallot. So I'll show you a corresponding CT image. So normally the arch should be here. So if you can see the impression of arch, aortic arch is missing here. And there is some kind of impression here. And if you look very carefully, the trachea is kind of indented here. So this is also one of the clue that you should look for if it's a right-sided aortic arch. Okay, so this is a exactly corresponding image of the same patient. And you can see that the arch is going from this side. This is like an aberrant left subclavian artery that is going from here. Okay, so this impression is basically of the aberrant left subclavian artery, but that's a little higher level. So we'll just stop right here that it's a right-sided aortic arch. Okay, so we'll go to the next case. So what is the modality? And I'll start the timer. Just write whatever you feel like, okay? X-ray, CT, MRI, you have 3 or 4 options only. Okay. So people have started answering. Other people also attempt, don't think much. Okay. Okay, so we'll stop right here. It's an IVP. Some of you guessed it right. It's an IVP, intravenous pyelogram. So you see these are all the calyces and this part is the fornix. These are all the calyces and this part is the pelvis. And then you see the ureter and then you see the urinary bladder. So the whole length of the ureter is not visible. Why? Because of the peristaltic movement. So sometimes it's visible, sometimes it's not visible. So you don't call it pathological if the whole length of ureter is not visible. Okay. So the next abnormality, can you see any other abnormality? You can see this kidney shadow. This is the right kidney. This is the shadow of the right kidney. This is the shadow of the left kidney. Okay. So this is the normal part and this is the abnormal. So what do you think it could be? It's a very famous sign, if anyone can guess. Okay, people have started guessing. Some of you are getting it right. Okay, please everyone respond, take part in it. So I'll wait for 15 seconds more because at your semester I won't have been able to answer this. So, okay, we'll stop right here. So this is the drooping lily sign. Amisha guessed it right. So this is the drooping lily sign. And this is basically seen in when there is duplication of pelvis or duplication of ureters associated with it. Okay, so ureters you can't say, but duplication of pelvis you can say. So basically in duplication, there are going to be two moieties. There's going to be an upper pole moiety and there's going to be a lower pole moiety. So the upper pole, if the upper pole moiety is enlarged or even if there is a mass, so it is going to put pressure on this thing and this looks like a drooping lily. So you can see that it is drooping. Another place where you see another similar sign is water lily sign. If you all may recall, that's like seen in the hydated cyst. Just to compare the names and all. And remember, so this is the drooping lily sign. It is seen in cases of double renal pelvis, usually seen in the lower moiety. Okay, and there's another rule associated with it that's called as Vigard-Smear rule that is related to the insertion of these double ureters on the bladder. So the lower pole moiety ureter is going to insert on the normal position, while the upper pole one is going to insert a little lower and medially. Okay, so you can remember that the upper pole one is more commonly associated with ureterocele. So how I used to remember it was like easy mnemonic, the upper pole for you, and then it is associated with ureterocele. Okay, and the lower pole one is associated with vesico-ureteric reflux. Okay, so that is why it is important, and it's a typical sign that is known as the drooping lily sign. So this is quite an easy one. So what is your diagnosis? This is something we all should know. Even if we don't know, that's not a problem. But if you see this case anytime again, you all should know what this is. Okay. Please, more people can participate. I can see there are 69 people listening. Okay. So what is this modality? Please type your answers in the chat box. Okay, so it's an X-ray. That's pretty obvious. It's an X-ray. So we'll just look. So these are the two leaflets of diaphragm, the right one and the left one. Now, if you can see, this is air. Like this much is air. So if you have air inside the peritoneal cavity, what is your diagnosis? Free air within the peritoneal cavity, not within the bowel, but within the peritoneal cavity. Yeah, exactly. So it's going to be pneumoperitoneum. So pneumoperitoneum, so you should always be able to recognize signs. There are many signs of pneumoperitoneum, but this is one of the most common signs that you're going to see. If you see free air under the dome of the diaphragm, or you can see the central tendon of the diaphragm that you can see because it is being lined by air. So there's going to be air beneath the surface of the diaphragm that is going to make this central tendon visible. Okay, so if you can see that, that is a sign of pneumoperitoneum, and you should always suspect pneumoperitoneum in such cases. Another sign which you can see here is called as the Wriggler's sign. So what is a Wriggler's sign? Basically, if you look here very carefully, you can see the layers of the bowel. Like you can see that this is one of the bowel wall and this is another bowel wall. Okay, so you can see both the aspect. But in a normal X-ray, you can see air within the bowel, not the walls of the bowel. So why can you see walls of the bowel in this case? Because inside it is going to be lined by air, which is normal. But since the air has come outside, there is going to be a contrast between these two and the wall is going to be visible. Okay, so when you see wall of the bowel wall, then you know that it could be Wriggler's sign and it could be a sign of pneumoperitoneum. In this case, it was massive pneumoperitoneum, so it was pretty obvious. And obviously, it was because of obstruction. So you can see some air fluid levels here. So this is another important thing that you can see the cause, that it was because of obstruction and then it perforated and then it led to pneumoperitoneum. Okay. So another sign that is associated with pneumoperitoneum, I'll tell you, is a sliver sign. So what is sliver sign? This is the falciform ligament of the liver. So the concept is same. Normally falciform ligament is not visible because it has soft tissue densities on both the sides and it is itself a soft tissue density. But if it is lined by air, as you can see, this like these shadows, these are all like the opacities or densities of air. So you can see this falciform ligament quite clearly. So this is known as sliver sign. This is another sign for pneumoperitoneum. But the most important thing you all need to remember is that whenever you see free air or gas under diaphragm, that means it could be pneumoperitoneum and you should suspect pneumoperitoneum. Okay. So we'll go with the next question. So what is your diagnosis? I'll give you all 30 seconds. Yeah, people are going in the right direction. It is some kind of sign, okay? It is a very common sign that is associated. Okay, other people, please take part. I'll give you all some more time. Okay, at least you all can say that there is cardiomegaly. This everyone can appreciate, I hope. Okay, so we all can appreciate that there is cardiomegaly. So how do you know? First thing I'll let you know that how do you know that it's a cardiomegaly? Okay, so you take cardiothoracic ratio. In adults, if it is more than 0.5, and in pediatric population, if it is more than 0.6. Okay, so you take the maximum diameter of the heart shadow and then you divide it by the maximum diameter of the thorax. So here, objectively, you can just see that there is cardiomegaly. So someone said box-shaped heart, that was right, because if you can see that there is some kind of indentation here, it's not very close to money in bag. And to be very frank, I also get confused. So not to worry about, just understand that there is some kind of anomaly here at your level. There is some kind of anomaly. There is cardiomegaly, and it could be either of the two appearances, either a box-shaped heart or a money bag. This was frankly the box-shaped heart. So can anyone say in which anomaly do you see box-shaped heart? Please type your answers. So, okay, most of you got it right. It's Epstein anomaly. Okay, so what's the basic problem in Epstein anomaly? So in Epstein anomaly, there's an abnormal tricuspid valve. So what happens is that the tricuspid valve, which is present between the right atrium and right ventricle, it is prolapsed. Okay, so it gets prolapsed within the right ventricle, and therefore the right atrium is enlarged. So what you see here is the shadow of an enlarged right atrium. As I told you earlier, that the right side of the heart, the right mediastinal border of the heart is formed by the right atrium, superior vena cava, right atrium and right ventricle. So this is the right atrium. Okay. So we'll go to the next question. This is a typical question. So if you ever see this thing, there's like no other differential. This is the diagnosis. So I'll give you all 30 seconds. Just try to write the finding. The finding is also enough. I'll just point towards the site. So this is the area where you can see there's some kind of scalp swelling. The patient came with the complaint of scalp swelling. So you can see there is some scalp swelling. There's some bony spicules radiating from here. Okay, so someone said hair on end appearance. So always remember, hair on end appearance is going to be diffuse. Okay, so it is seen in cases of thalassemia. That's a systemic disorder. So it's going to affect the skull diffusely, not focally. So a good interpretation of the finding, but this is basically a case of cavernous hemangioma. Okay, so whenever you see these kind of focal area with bony spicules, then you know that it's a cavernous hemangioma. It's seen on both the sides. And basically, this is cavernous hemangioma. All these impressions you see are sinusoids, which can be seen in cases of cavernous hemangioma. So they are not vascular malformation according to the new terminology. They are basically benign neoplasms. Okay. the vascular channels. They are not arteriovenous malformations or any kind of malformation. Okay, so it can be removed and it can be treated in a different way. So I know this was kind of a difficult one. So we'll go to an easy one. So what is your diagnosis? I'll point out the finding, okay? So it can help you all a little bit. This is basically the finding in this area. Okay, so it's near the right hilum region. Okay, so you all can start answering. A very good differential. Okay. So I'll give you a clue. The patient is usually suffering from different kind of allergies and have an elevated IgE levels. I'll show you a corresponding CT image also, so you can see. Okay, come on, people, start answering. People have started answering the right thing. You can see that this is the finding. Ignore this one, I'll explain what this means, but this is the one that is corresponding to the X-ray anomaly. Okay, yeah. So Himanshi and others got it right. It's a finger in glove appearance and it's seen in ABPA, allergic bronchopulmonary aspergillosis. So usually associated with patients that have allergic symptoms like all these is associated with asthma as well. Okay, so what happens in finger in glove appearance typically is that there is going to be dilation of the bronchus. So what you see here is the end-on view of a bronchus. Okay, and then what happens? Mucoid gets impacted within these bronchus, and that leads to finger in glove appearance. So it is similar to the finger in glove appearance. So you can see here, these are basically this was basically a dilated bronchus. Okay, and then mucus got impacted in this. This is an HRCT image, high resolution computed tomographic image that we use particularly for lung imaging. And here you can see all these impacted mucus within these. So you should know that this is ABPA and the typical appearance is finger in glove, and why it happens? It happens because of mucoid impaction. Okay, so we'll go to the next question. Okay, so what is your diagnosis? Just look carefully. So these are all things, if you are posted in emergency, you should know. Okay, so the patient came to the emergency with the history of RTA. Okay, so people are getting it right. Okay, good. So most of you got it right. So this is a pneumothorax. So you all can see this is the right-sided pneumothorax very prominently. So how do you know that this is a pneumothorax and not a normal lung? First of all, you can see this interface. So, okay, so this is the interface that shows that this part is the normal lung and this part is the pneumothorax. Okay, so pneumothorax is what? That is air within the pleural cavity. Okay, so now you can see that up to here you can appreciate these small bronchovascular markings. Okay, and here just look at the normal side of the lung. You can appreciate these bronchovascular markings going up till here. Okay, they're all going up till the periphery. So you can appreciate these, but here you won't be able to appreciate any bronchovascular markings. Why? Because in pleural, within the pleura, there are going to be no bronchovascular markings. So this is air within the pleural surface. So this is very important to differentiate, and the most important sign, if you ask me, is that no bronchovascular markings will be present whatsoever within the area of pneumothorax. Another sign that's here is called as the Neclario V sign. That's a little higher, but then the important thing is that you cannot appreciate any bronchovascular markings here whatsoever, and you can see this very clear interface between the normal lung and the pleura, that is filled with air. So pneumothorax is an important entity and you should be able to recognize this or at least suspect it in case you're posted in emergency. Okay. So we'll all go to the next question, another emergency based question. So what is your diagnosis? This is an X-ray, abdomen, erect and supine. You all can answer this. Come on. You can just forget about this one. This might confuse you. Just look at this one. I'll give you all time. I want everyone to answer this question. This is very important. Okay, come on, people. So all of you are getting it right. Okay, so I'll let you know the answer. The answer is right. It's a small bowel obstruction. So what is the most striking thing that you can see here? So you can see here multiple air and fluid levels, right? So there are multiple air fluid levels. They are like in a stepping pattern. So you can see multiple air fluid levels. You can see the this is not an air fluid level. This is the shadow of the stomach. Okay, so the fluid level within the stomach. So this is normal. If you see it beneath the left diaphragm, left dome of diaphragm, this is a normal finding. And here you can see that there are some bowel loops that are probably dilated. Okay, and but they are not present in the periphery. So if such kind of bowel loops are present in periphery, then you think of large bowel obstruction. But if they are present centrally, then you think of small bowel obstruction. Okay. And now another important thing is, I think you people must be aware of it, is the 369 rule. So what does that mean? That means that if the dilatation of the small bowel loops is more than 3 centimeter, the dilatation of the large bowel loops more than 6 centimeter, and dilation of cecum more than 9 centimeter, then you call it as definitely distended or dilated bowel loops. Okay, so this is one important thing. Another thing is that you should be able to know that there are multiple these air fluid levels. Okay, so these air fluid levels, there's a criteria actually radiologically. So there should be more than 2 centimeter difference in the height, and they should be more than 3, up to 3 or less than 2, like they can be seen normally also. But you can see these. Okay, and if both large and small bowel loops are suspected or dilated, I'm sorry, so you can also suspect paralytic ileus. Okay, so in this case you can't see any large bowel loops, you can just see small bowel loops, and you can see multiple air fluid levels. Again, in such cases, look for pneumoperitoneum. There should be no sign of pneumoperitoneum. Okay, so there are some also impending signs of pneumoperitoneum or rupture. I'll let you know that if the dilated bowel loops are stagnant, like at for example 12 o'clock you saw that there are some few dilated bowel loops. Okay, and then you again took an X-ray at around say 3, and then these dilated bowel loops are still in the same position. Okay, so this is also a sign of rupture, because they should not be in the same position all the time. Okay, and then later on pneumoperitoneum is a definitive sign. Okay, so this is basically small bowel obstruction. You can see multiple air fluid levels, and as someone said it right, step ladder pattern. So we'll go to the next question. This is a skull X-ray. So you all can start guessing now. Okay, I'll give you all 30 seconds. So just see on the left side, you can see that there are multiple, some curvilinear kind of thing, like calcification kind of thing. So multiple curvilinear calcifications only in one side of the skull, probably affecting the brain. Okay, so I guess this was a little higher level. So this is basically, all of you can appreciate at least these curvilinear calcifications, right? Just look here. So what do you think this could represent? What structure do you think it could represent inside the brain? Okay, so it could represent a gyrus. Okay, so all of you know that they are like convoluted structures. So you can see all these convolution kind of calcifications. So these are basically gyral or gyral calcifications, which you see typically only in one part of the hemisphere. Then you definitely suspect Sturge-Weber syndrome. Okay. Yeah, so someone got it right now. I think after describing the finding, you people can get it right. Okay, so this is Sturge-Weber syndrome. So this is typical finding, no other differential. You just think of Sturge-Weber syndrome when it is present only in one side of the skull. Okay, so there's another finding here that this part of the frontal sinus is more dilated. If you compare it from this side, this part is more dilated. So there is pneumosinus dilatans on one side only, that's the left side. Okay, so this is Sturge-Weber syndrome. Okay, so we'll go to our second last question. Okay, so what do you guys think this can be? So I'll describe it for you guys so that you people can find it easy. First of all, this is a scanogram, so it is very similar to the X-ray, to lateral skull X-ray that you all see. So you can see that the skull bone is thickened, okay? And there is some kind of protuberance here in the frontal aspect. All this occipital and all this area is not very thickened. This part is much more thickened, okay? You can see that all these diploic spaces are widened. There are multiple like these fluffy kind of opacities, cotton wool if you may. So now you all can start guessing, I hope. Yeah, keep on guessing, people, you're going right. So I'll ask the direct question, where do you see all these fluffy cotton wool kind of opacities and enlarged or dilated diploic spaces with widened skull vault? So cotton wool skull is like the question. And there's another important finding here. Okay, so it's Paget's disease. Anamika got it right. So it's Paget's disease. You can see that there are multiple small, as if fluffy kind of opacities. These are called as cotton wool opacities. Okay, and another sign is the Tam O'Shanter sign. Okay. Yeah, it could have circumscripta appearance, but Anamika, what you need to remember is that in circumscripta appearance or osteoporosis circumscripta, as you called it, it's basically a lytic lesion. So you will be able to see like this, a lytic lesion here in the frontal bone. Okay, most commonly in the frontal bone. So you don't see any large lytic lesion here. What you can see is that these small lytic lesions, but these are not lytic lesions. These are basically diploic spaces, which are enlarged. And there are two things which you need to remember in this thing, Paget's disease. If you see thickening of cortex or an enlarged skull vault with coarsening of trabeculae, so that is very typical of Paget's disease. And if you see it anywhere in the body, any bone in the body, you suspect Paget's disease. Okay. So why is it important? Because what happens is that in skull vault, what happens is that it causes compression of all these foramens. So the nerves and the vessels that are going to pass through this foramen are going to be compressed, and there can be symptoms related to cranial nerve palsies or even vessel occlusions. Okay, so that is important. And this is enlarged diploic spaces with thickened skull vault and cotton wool appearance. Okay, so we'll go to the next question. This is pretty common again, pretty obvious. It's a chest X-ray. There is some finding on the right side, a pediatric X-ray. So you all can start guessing now. Okay, so people have started guessing. You're all going in the right direction. Okay. So I'll provide you with the corresponding CT image. So let's see if you can diagnose it now. This is the same corresponding CT image. Just look here. So this is the lung. These both are the lung place, and this is some kind of hair opacities that is coming. It is coming from here, from within the peritoneal cavity. So what do you think this could be? Some structures herniating from the peritoneal cavity into the thoracic space, compressing the lung. What do you think this can be? Come on, I almost gave the answer away. Okay. Okay, so I think I've exceeded my time. That is why no one is answering. So it's basically congenital diaphragmatic hernia. Adarsh got it right. So this is congenital diaphragmatic hernia. You can see that there are multiple in X-ray. So I'll explain the X-ray first. You can see that there are multiple cystic kind of spaces that are seen within the lung parenchyma, if you may say. But if you see that there is some kind of communication that is seen from here, from within the peritoneal cavity, you are not able to appreciate the diaphragm in this side. Okay, so you can see the diaphragmatic leaflet here very clearly. But on this side, you can't see any diaphragmatic leaflet. So what happens in congenital diaphragmatic hernia is that the bowel loops are going to herniate from here into the thoracic cavity. Okay. And why it is important to recognize? Because it can cause compression of the lung parenchyma and that can lead to respiratory distress in the newborns. Okay. So this is congenital diaphragmatic hernia. There are two common types. We all know one is Bochdelic and one is Morgagni. Okay, so another a small kind of weird mnemonic for all of you. So for Morgagni, just remember it is going to be anteromedially. So M for Morgagni, M for medially. So anteromedially, if you see a defect on the anteromedial aspect, then you think of it as Morgagni hernia. And just opposite to medial would be lateral and anterior ka opposite posterior. So posterolaterally, it is going to be Bochdelic hernia. Okay. So there are two types, Morgagni and Bochdelic, and you should understand that this was basically Morgagni hernia. It was on the anterior more aspect. Also, it was kind of mixed. So don't comment on just this single image. You need to see the complete dome of the diaphragm. But just for the mnemonic purposes, Morgagni and Bochdelic, you should remember. And just label this as congenital diaphragmatic hernia. If you see cystic spaces within the thorax, hemithorax, and it is seen communicating from the peritoneal cavity, think on the lines of congenital diaphragmatic hernia, especially if the patient has presented with respiratory distress. Okay. So we'll go to the last question for today. This is kind of tricky one. So I'll let you know the findings. Okay. There is some kind of opacity here, and there's some foci of calcification within that opacity. So what do you think that opacity or lesion could be if there are some kind of calcifications? Just don't think, just think that there is a lesion and it contains calcification within. So what can you call that lesion? So I'll show you the corresponding CT images. I'm pretty sure. Yeah, someone is trying to describe the findings. That's right. There is mediastinal shift, right? And the trachea has been shifted towards the right side. Okay, so that means the lesion is predominantly occupying the left side. Very good. Any other findings that you can appreciate? So I'll show you the CT. I hope you'll all be able to diagnose it then. This is the contrast enhanced coronal and axial images of the same patient. Just look at this lesion. So what do you see? You see some foci of calcification, you see some foci of fat. What do you think this could be? This is the aorta, it is compressing the aorta. This is the trachea, you see it is shifted towards the right side and there's this huge lesion here. It contains calcification, it contains fat and it contains soft tissue density. Now you all can guess what this lesion could be. Just think about the constituents: fat, calcium or bone, and soft tissue containing lesion. So you have all the three layers, derivatives. Okay. Come on, I want everyone to answer this. Okay, it's the last question. I'm not going to bore you any longer. So, okay. Come on. So I'll wait for 5 to 10 seconds more. Okay, so many of you got it right. It's a teratoma or a dermoid, whatever you may. So you can see that there are derivatives from all the three layers. You have fat. This density is fat density. Okay, so you see it here, you see it here, even you see it on the periphery, and this is calcification. So you see this is the ribs, these are the ribs. So it is similar to this. Okay, so these are calcifications. It was kind of difficult to appreciate without changing like the window settings on the X-ray. That is why I thought I'll show you all the CT images. So this was the calcification and these were all the fat and this is all the soft tissue density. So if you see all the derivatives from all the three layers, just don't think this is a teratoma. Okay, so that is important. Someone said lymphoma because of lobulated margin. You're right, lymphoma has lobulated margins, but this lesion doesn't has any lobulated margins. If you see, it is like kind of smooth walled. There are no lobulations here. And another very important finding that you need to know to differentiate lymphoma from teratoma: lymphoma is not going to have calcification, fat, and it is going to have a homogeneous enhancement. So here you can see that it is heterogeneous. This place is like not very enhancing, this place is enhancing, maybe not enhancing. But in lymphoma, you will always have like a very homogeneous enhancement, no foci of calcification whatsoever in any lymphoma in the body. Okay, unless it is treated, no lymphoma in the body is going to show calcifications. And fat to bilkul bhi nahi. Okay? So you have fat, you have calcification, and you have soft tissue density. So this is basically a teratoma. So this is something you should all remember. It can be present anywhere in the body. Most commonly you see it in ovaries. This is an anterior mediastinal lesion, anterior mediastinal mass lesion. So it's a teratoma. Okay. So I'll close my class here. I hope you all enjoyed it. If you all have any questions, you can ask. I'll give you all some time in case you want to ask any question. If no, then see you all next time. Okay, so I guess all of you understood. Chalo. So see you all next time. Bye bye for then. Bye.